wait for the computer to tell me it's 9 o'clock with a pretty full agenda. Okay, I have it that it's 9 a.m. On February 2nd, 2021. And I'd like to call to order the OEB Strategies on Evidence and Outcomes Work Group. And to start, I'd like to do a quick check on OEB CL members present. Jeff, are you here? Okay. Bill, are you on board?
Here.
Thank you. Robert. Okay, so I haven't heard from Jeff, and I haven't heard from Robert, so we don't have a quorum.
I had a stuff.
Oh, okay, thank you. So we have a quorum, and Jeff, when you jump on board, just say you're here. But we have a huge agenda to get through today with lots of meaty stuff. So I'm going to go ahead and move us forward. And the first item on the agenda is the January meeting synopsis. Any issues or questions about that? Otherwise, I'll accept a motion to approve.
I'll move we accept the January meeting synopsis.
And I will second.
Okay, all in favor? Aye.
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 Okay. So we are ready to jump into the OEB pharmacy report. This comes to us from our consultants, Willis Towers Watson. Brad, I see your name at the top of the list. Are you going to introduce this, or is Jenny, or how are we going to do this?
Yeah, I'm going to go ahead and introduce this, and then myself and David Lamb will be presenting. David, I don't see your name on here anywhere, but I assume that you're on the call as well.
I'm here, Brad.
All right. So this is the time of year where we pause for a moment in the midst of all of our planning and strategic items and kind of take a quick look back at the performance of the prescription drug plans for both the MODA and the Kaiser carriers for the latest plan year. In this case, we'll be looking at the 2019 to 2020 plan year. And doing not only looking at the current year, but also looking back and seeing how the plan has performed over a number of years to get a little bit of trend and idea there. We're going to look at our per member costs, including, by drug category. We'll be taking a look at some key metrics such as our generic utilization and mail order utilization. We're going to be looking at trend drivers, specialty performance, and a number of those things. But before we really dive into the numbers, David is going to kind of give us an overview of the current market state of pharmacy. And so with that, we can move on to, let's see here. I'm not sure how these slides, there we go. Slide 4, thank you.
Well, perfect. Thank you so much, everyone, for having us here. I'm David Lamb. Just a quick little background about myself. I am a pharmacist by trade, so being in healthcare, I do get deep into the weeds, but for this presentation, I certainly want to keep it as high level as possible and really make it digestible and really focus on the overall trends that are going on. So we really picked 6 key themes for the overall topics in healthcare. I'll start with the upper left-hand corner with the peaking topics in pharmacy. What's peaking right now is certainly what is the big thing in pharmacy? Pricing. We look at the drug pipeline, we look at all the drugs that are emerging, And one of the big things is just how expensive they are. And obviously there's new technology in the mix, but that is certainly one thing to keep in mind, is that pricing is right now quite top of mind in pharmacy. So pricing transparency, pharmacy transparency, that all comes along with it to ensure that there is the value in these pharmacy type medications. Another big one that's peaking, I think, in the past, almost year now, has certainly been COVID. If you look at that third bullet, COVID vaccines, we know that that is certainly a big topic with having rolled out phase 1A, now moving on to phase 1B. And phase 1A was just making sure that the staff, the first line workers had got the vaccine. And now when you moved on to phase 1B, we certainly tested the infrastructure and the supply and demand. With phase 1B, it opened up a lot more eligible members or patients who were eligible for the vaccine versus what was available on hand. So that's certainly a topic that you're hearing right now in the news. That's certainly one that's peaking. And then, of course, another one I'll just highlight real quick on the peaking in terms of what's going on in the marketplace. We're seeing new players in the marketplace, one being, Amazon Pharmacy. We're certainly hearing some headlines, so probably not so much of a surprise to see that make it on the list as well. But that's certainly just a quick summary of some items that are peaking. The other ones I think are a continuation of what we know. I'll move on to the next one below peaking, which is the persistent challenges. Those are the things that we had talked about in terms of cost, but things that help with cost. I'll focus on the role of the biosimilars and why we say that. Biosimilars are specialty drugs, but are more of what we would call a generic product. Specialty drugs do get a patent, and when they lose their patent, they don't call it a generic, they call it biosimilars because they're biological agents. So as we're seeing more of the biosimilars emerge onto the market, we're certainly seeing not the traditional adoption of the of the generic biosimilar products. We're seeing sort of a mix. Some might stick with some PBMs, or health plans will stick with the branded product in terms of favoring overpricing. Rebates play a part into that in terms of the overall net cost. So those are some of the persistent challenges that we're seeing. So overall, it's affordability. That's what we're seeing as persistent challenges. Then the incremental momentum. What are we wanting to do? We really want to see more value-based opportunities, and certainly looking at drugs that show the highest value and also coming in at the most reasonable cost. I won't even say most affordable, but what is most reasonable when you have a lot of drugs that are similar on the marketplace. We really want to make sure that there's now an opportunity to highlight what is the most valuable medication on the market with the best outcomes and overall lowest net cost. These are the other levers that are part of the incremental momentum. Certainly formulary management, network management, and of course, how do we continue to make things affordable for members at the point of sale? And one of those is a rebate opportunity to decrease that price. So then I'll move on to the upper right-hand side, which is the specialty pipeline. I alluded to that just a little bit earlier. I'll just bring your attention to the second, or that sub-bullet in that first bullet. Specialty drugs with new emerging technologies, you probably have already heard, ranging from prices of $400,000 to $1 million in gene therapy. And later in this deck, we'll certainly show you some new drugs that are already hitting up to the $2 million price point. And this is per infusion or per administration. So, a lot more expensive than, let's say, maybe 10 or 15 years ago, when maybe the most expensive drug might have been $1,000 on the pharmacy side, $1,000 per year, or maybe $100 per month. Those are quite expensive. And now we're seeing, 6-figure prices, and now 7-figure prices for medication. So that's certainly the specialty pipeline to watch for. And then overall emerging trends, you know, being very focused, we're seeing, as we think about cell therapy, gene therapy, we think about the pharmacogenomics, and that's just a, you know, just a fancier term in terms of pharmacy or drug management honed in with genetic code. So now as we dive deeper into technology and we have the capability, now we're starting to identify how can we make drugs most effective for certain genetic components or genetic markers within members and patients. So those are certainly some things that we're seeing emerging. And we're also seeing, of course, specialty copay, you know, how do we make drugs affordable and ensure that these drugs are continuing to be affordable for these members as the drugs continue to, you know, skyrocket beyond, you know, even what members can, you know, will make in a lifetime. So those are some things that are emerging in terms of overall trend. And because the drug prices are, you know, going up, regulatory is certainly a key component that we want to continue to watch out for. So certainly we hear a lot in terms of executive orders, affordability. We hear a lot within the CMS space in terms of, you know, what are the opportunities for pricing and what are going to be accepted for what we're going to move on in the future. So those are the things that we're certainly looking at. We did also put in the CARES Act because that certainly put affordability first and foremost for members and ensuring that as we're working through the coronavirus, that there is affordability for them on the vaccine, on treatments, and also testing as well. So those are, that's pharmacy hot topics in a quick nutshell. I'll pause for a quick moment. I know I went through a lot. Any questions that come from that slide? Okay. If not, then we can certainly move on to slide 5. So when we went through the data, here we just wanted to certainly highlight some of the key observations. What was incredible, and I think this is continuing year over year, is that MODA and Kaiser are certainly beating our overall database benchmarks when it comes to allowed per member per month cost. We'll highlight that for you. You know, that's a great kudos. But certainly one of those things that we want to watch for is just how is that trending as well. Kaiser certainly had the lower of the PMPM, and we'll highlight that for you. Brad will certainly do a great job of highlighting that. And if you look at the MODA plans having they did have a higher cost share. And so we'll look at the overall percentages, and we'll show that to you as well. When it comes to utilization, there was an increase in what I had talked about, specialty drugs. There was an increase in utilization of specialty drugs. So we'll certainly highlight what's going on. I'll certainly just provide a commentary, which is, you know, with specialty drugs, it certainly seems like there's a step therapy along with it, which is we are trying to ensure that the lowest cost drugs are being utilized first before they jump to the specialty drugs. But overall, being there in the marketplace, members are, I would say, not getting the best impact or effect that they were hoping for these traditional medications, and then moving on to these specialty drugs when they don't get the progression that they're hoping for on disease management. But with that said, we're still seeing generic drug utilization being extremely high within the overall Kaiser plan as well as the MODA plan. So very, very impressive. We'll certainly highlight that as well. And then what we're also seeing is the MODA plans being more affected by drug mix and new drugs on the market. We're certainly seeing that being one of the main drivers within the MODA plan as well. So that's the key observations, and we'll certainly present the data to support these pieces as well. If there's no questions, I'll certainly move on to the next slide. So a lot of good changes we wanted to highlight in slide 7. You know, starting from the 2017, 2018. A lot of good opportunities. One that I'll highlight here is utilizing site of care program, and why we were seeing that as emerging trends or use of
Something go wrong, or is it just me?
Yep.
David, I think you may have been muted somehow.
Yeah, that's what I thought too. I'll just unmute myself if that's okay. I noticed that. I would have continued to speak and not even realized it, but thank you. All right, so let me just go ahead. I'll just continue with just the site of care. Overall, site of care is really important because we really want to ensure that there's convenience for the members and that they're also getting the benefit of a lower cost opportunities as well. And so we're certainly seeing that as a topic that's emerged for the last 6-7 years, and we're glad that that was implemented early on and really ensuring that best practices are being implemented. Formulary management in 18 and 19, so just the high performance formulary. And what that is for us, implementing exclusions for certain drugs. We've seen drugs that have emerged on the market, high cost, low value, great reasonable alternatives. Those are certainly ones that we want to make sure that if there is good alternatives at a lower price point, let's go ahead and utilize that. I'll give a quick example. There's drugs on the market that combine ibuprofen and Pepcid together, right? And they'll charge $600 for a drug per month of that drug. We know ibuprofen, Pepcid, you can go to Costco, you can go to your local pharmacy and get that easily for $30. And so with these new type of opportunities for convenience, is it worth the value and cost? So implementing a high performance formulary, evaluate something of that magnitude, and certainly a good practice to have implemented. And for Moda, having implemented the Choice 90 RX, that's allowing for 90-day supply at the retail side. We're certainly seeing that as another emerging topic and a good thing to have implemented because sometimes members do want to be local. They do want to go down to their local pharmacy and get a 90-day supply versus the mail order side, which has a little bit of inconvenience for members. But if they get used to it, they'll certainly appreciate the having drugs delivered at the doorstep. But for those who want the more familiar experience, that's certainly an option, and also better pricing as well. So those are some things that we thought was good continuing practices. And then overall, benefit optimization in the 19 and 20 year, and with Kaiser having implemented coverage of reproductive health or women's preventive health. Those are also good things to ensuring that some of these drugs are getting the best coverage for your members. So good things that are coming down.
Quick question.
Of course, Tom.
Quick question on the reproductive health coverage. Was that part of ACA, or was that just I don't remember the details. Was that an independent decision on the part of Kaiser Permanente to make those at no member cost share?
Yeah, I think.
David, sorry, this is the voice from Jenny just popping in, but
I was going to call on you, Jenny.
It really, Tom, was just an expansion of drugs, a variety of drugs that were covered before with no cost sharing. And it had to do with the ACA expansion of all preventive services, not specifically reproductive health.
Okay, thank you.
Yep.
Thank you, Jenny.
Yeah.
And so for the upcoming year and what's the 20 and 21 plan year, we're certainly seeing additional expansion. So, the Moda chemotherapy oncology site of care. So typically site of care was for non-oncology medications. So now the expansion into looking at adjunct or supportive type drugs for oncology is, I think, phase 1, and phase 2 is looking at the oncology type medications that will certainly help with that. So those are some things that we're seeing. And of course, I'll just highlight just real quick, which is that fourth bullet, cellular and gene therapies. It's a good thing to evaluate the opportunities within cellular and gene therapies, knowing how expensive these medications are. So there's some best practices and maybe some centers of excellence being being coming down the pike for that as well. So those are the plan changes that we've seen and what we're also anticipating for the future. Any questions? Any other additional questions?
It's just that when you make changes, the question is how does the membership deal with it? As it improves our cost structure, everyone's happy about that, and then the question is you balance it against quote inconvenience. I don't remember us hearing any significant pushback from any of these plan changes that we've done over the last 2 to 3 years. Is that accurate?
I'll just jump in again. I haven't heard any significant feedback, but I think that would be a good question to pose perhaps directly to Moda or Kaiser, but mostly Moda.
Okay. So that's one of the, go ahead.
I was just going to say, if I'm looking at, some of these, the convenience has increased, the chemotherapy outside of the hospital setting, the infusions, same way, focusing more on mail pharmacy. It seems like the convenience increases rather than decreases.
And this is Ollie. I think in general, we mostly hear from members when there's a medication that's dropped from the formulary. I don't think there's been a lot of inquiries from members about these benefit changes.
Okay, because the site of care has been a huge, with significant variability in cost for the same thing. It's one of the obvious things to focus on. We're doing it for all of healthcare. We're trying to look at the expensive places, where there's no difference in the product, in outcomes and quality. So it's an important point. We need to have our antennas up for this. But the important aspect is that we've been able to do these changes that have had impact with really not any, it sounds like not any significant pushback in regards to our membership. So it's kind of win-win.
Hi, Tom. This is Katie from Moda. I just wanted to confirm that that's true. Moda hasn't heard a lot of noise from the programs implemented, like this side of care. And I just want to confirm that we always have the member at the forefront when these changes are making. We talk about at the board kind of cost savings, but I just want to assure you that we're very dedicated, and having pathways like exceptions for members who may not be able to be at the right side of care really goes a long way. Sorry.
Thank you. That's great. Okay. Sorry for slowing that down. I thought it was just an important part for us just to confirm. I think it shows that that things are going in the right direction.
Yeah, and I just highlight, Tom, which is certainly members have communicated that they are appreciative of having a new opportunity to have a home infusion, a convenience piece. So there's actually been a lot of praise behind the site of care opportunity as well. That's certainly been our experience of having seen that as well. Okay, I'll go ahead and pass it over to Brad to go through some of our key metrics and go through the data as well.
All right, so thank you, David. So we're going to switch from words and strategy into numbers. And so we've got just a few of our key performance metrics on slide 8 here. They're kind of grouped a little bit. We're going to look at both total plan costs, which is the allowed, and that's sort of before we take into consideration any cost sharing that the member may pay through deductibles or coinsurance, et cetera. And we'll look also at the plan paid, and then a couple of other key statistics that we've referenced a little bit earlier. So the first one is our total allowed cost, and this is the total per member per month cost of all the drugs before we consider the portion that's paid by the members. And so we're at about $78 for Moda, about $44 for Kaiser, And both of those are well below what we are finding or considering as best in class at $115. So, very successful management. We've seen that in the past, and that does continue. Kind of pairing with that, if you actually go down instead of across, we take a look at how those costs have changed over the last year. So that $78 for MOTA is a 6.6% increase, which is frankly below our, our kind of the national expected pharmacy trends we've been seeing. And Kaiser's cost of about $44 was actually a slight decrease from the prior plan year of 0.5%. So very good performance on the Kaiser plan. Something we do not see very often in the marketplace at all. When we shift over to the middle, this is showing the plan paid per member per month cost. So this is the amount of benefits that's actually being paid out of the plan, and does reflect that members are paying co-pays and co-insurance, et cetera. And so for MOTA, we're at just about $67. For Kaiser, we're a hair under $40 at $39. And best in class, again, much higher at just about $97. And so when we drop down, that plan paid is increased just a little over 5% for MOTA, and very consistent decrease at about 0.4% drop for the Kaiser plan. So, and we'll get into a little bit of more details on that, both from a member cost share perspective, but also from sort of what is driving those trends that we're seeing of the 6.6 and the negative 0.5 a little bit later. Kind of moving to the top right, that's our generic dispensing rate, or GDR. We're seeing very positive results from both MOTA and Kaiser. MOTA at 91.4 and Kaiser at 92.7. And both of those are exceeding the best in class, which has been growing and is now up to 90%. But we're still, even though that best in class has been moving, is a moving target, we're still ahead of that target by a good margin in there. On mail order utilization, MOTA is currently at 25%, but note, I don't believe that reflects the, that does include the Choice 90, kind of the retail that David talked about a little bit earlier, that was implemented a couple of years ago. And Kaiser is sitting at about 58% for mail order utilization. Any questions on those key statistics before we really sort of dive into the details? All right, we can move to slide 9. And many of you have seen this slide. There's a lot going on here. There's different colors and shapes and charts and graphs and everything. So we'll take just a moment to orient. We have the total per member per month costs in the table on the top. And this slide is just for MOTA. We'll have a separate slide for Kaiser.
I'm still on slide 8. Did it get advanced for others?
No, it did advance, Tom. We may just have a moment for your system to refresh.
Okay.
As the joys of the virtual meetings, right?
Yeah.
All right. Okay, so kind of starting out at the table on the top, you'll note that the familiar number of the $78.12 PMPM that we just saw, and the 6.6% increase of that number. And then we also, kind of going backwards, have results from the 16-17 plan year all the way, up through the 19-20 plan year. We see that the trends in general have been very low and stable. That's indicating that MOTA has been very effective at managing the total allowed costs over time. We had a 4% trend in the 17-18 plan year. We had some very good management items that were put in place in the 18-19 plan year at 1.5%. And again, mentioned that 6.6% is still well below what we're seeing on a national level for per member per month cost growth. So going down into the table below, we've got all kinds of different numbers and colors and everything. And, in general, these represent the different drug categories or tiers that we have in the MOTA plan, ranging from our value tier, which is sort of the purple with, I'm gonna sound like Lucky Charms here, purple with diamonds. The generic is the blue with the triangles. Our high cost generics and preferred brand drugs are sort of the magenta with squares. Non-preferred is our yellow with a circle, and our specialty is that very top line that we see steeply increasing that we'll talk about in a moment. And at the very bottom into the negative territory is our rebate offset. And that's kind of the larger circles in the dark gray line. And the story here really is that, while our, trends have been remaining, fairly low relative to market, they are still being driven by the specialty costs. And our specialty costs, did go up just about 16% from 1819 to 1920. That's frankly pretty in line with market. We are seeing market trends for specialty pretty high. And then the rest of the items were relatively flat. We saw a small deep drop in our high cost generic and preferred brand. Generics remained relatively flat. Non-preferreds were relatively flat, and our value tier was pretty flat. One other area of growth in a positive way from a financial perspective was our rebates saw a substantial increase, and you'll see they went from a -8 to a -10. When you take the rounding out of the picture, that's just about a 25% increase in the rebate value. So those rebates, as a reminder, are an offset to our plan costs. So very good performance in the rebates. And that reflects not, combination of drug mix, but also, very good contract negotiation and things as well. Any questions on the MOTA kind of different, drug tiers or categories and how those have changed?
So Brad, I just want to confirm, partly because it's a public meeting, all rebates are a pass-through on the MOTA plan?
That's my understanding.
Yeah, so an increase in rebates basically means we're driving costs down.
Correct. Yep.
Thank you.
Any other questions? Good clarification. Thank you for that. All right, so next we're going to look at a very similar slide for MOTA, and we're on slide 10 if you're not following along online. And we see there's kind of our $43.87 in the top chart. That was the -0.5% change. And as we go backward through the plan years, we see that those have been, either flat or falling, but staying very close to that 44 range. We saw from 1617 to 1718, also a pretty good drop in there of our plans, of our per member per month cost. And looking down, we do have a couple of, we do have a little more simplistic chart at the bottom with the lines. We have a few less lines. For example, rebates are not a driver or a large part of the Kaiser costs, and we do not have a value tier. We just have a generic, preferred, and non-preferred tiers, as well as specialty. So for Kaiser, our specialty costs did increase. They were increased, in the single digits at around 8%. And the rest of the different tier categories were relatively flat. We did see a very modest decrease in the generics from, $17 down to $16, but had our both brand categories, preferred and non-preferred, remain very flat in there. You'll note that just as a reminder, we see that green line and, with the diamonds and the magenta line with the squares crossed, just kind of had an odd crossing pattern from the 1617 to 1718 plan year. And, just as a reminder, we did have a reclassification of a number of specialty drugs from the specialty category into the preferred brand category, and they were some highly utilized specialty drugs such as Humira and such. And so that's just nothing wrong with that, but that's just how Kaiser is preferring to categorize those.
Brad, Jeff here. Obviously, these are results we like to see. Is there a tie-in here to a reduction in office visits or any other influences that drove this decrease in costs?
I haven't spent time personally looking through and sort of cross-referencing the medical plan performance to the prescription drug performance. I will say that would be a very challenging exercise in the current year, the 1920 plan year, due to COVID and the impact it had, particularly on the medical side. We did not see a lot of impact from COVID on the prescription drug side. We did see a little bit of spike early in the pandemic, but it is largely levelized, and we've seen sort of just, kind of normal ongoing prescription experience since then. That's definitely.
Brad, this is Tom.
Mm-hmm.
The other thing, it's a pretty profound difference between the MODA and the Kaiser plan in terms of their outcome. Part of it is explained by risk scores.
That's correct.
And so that's something to remember. And yet just the trend over those last the 3 years going from 16, 17 through 19, 20 plan year. We need to continue to understand what KP is doing and seeing whether or not how much of it is translatable. Now, I think that there are some things that we've discussed where you outlined in a previous slide the innovations that MODA has done over the previous 3-year period of time. Those, my understanding is many of those were already in place within the KP system. But it will need to continue to kind of mine how KP is doing this incredible, control of pharmaceutical costs, and continue to see how what parts of it are translatable for a more open system that we have with the MODA health plan.
Yep, agreed. Absolutely. Very good comments. Any other questions or comments on the Kaiser kind of trend components or category increases?
This is leading up to good news, right, Brad?
This is good news. Anytime you have a negative drop in prescription drug costs, I think is amazing news. So, as well as the MODA at 6%, that's really great news as well. So kind of move on to the next slide. And this is where we're going to take a quick look at our trend drivers. Here we take our 6.6% change for MODA and our negative 0.5% change for Kaiser, and we take a look at what's driving those. We've got four main categories for MODA and 3 for Kaiser. We categorize that for MODA. The first one is more a utilization and product mix. And then we have a unit cost and a product shift and a change in rebates. And we can kind of see, we'll spend just a little bit of time on this because we see that the main driver for the cost increase of the per member per month, for the $78.12 is utilization and product mix. And, we spent a fair bit of time talking with MODA about that categorization and characterization. And, in general, I think what is captured here is more a product mix than a utilization. So utilization, not only in this case, means how many scripts are being used, which actually did go down a little bit year over year, but also what types of drugs are being used. And so this, I think this really reflects more a shift into more specialty medications and fewer traditional medications in that. So important distinction to make there from a utilization standpoint. On the unit cost, which is a
Brad, could Could I ask it? I'm probably jumping ahead. So what's the difference between product mix and product shift?
Very good question. And we did spend time on that too. Let's just move to product shift really quick and talk about that as well. The product shift was a very distinct category for MODA that reflects new drugs that are being utilized that were not being utilized in the prior plan year. And so, generally, I think they're new, but they could be drugs that are no longer being used or have been taken off of, the formulary or discontinued or disallowed as well. And I think an example of that, and, MODA can jump in or slap my hand later, but an example of that could have been a few years ago, we had a lot of issues with compound medications driving a lot of cost. And, we saw PBMs taking a lot of action to eliminate those and not cover those types of drugs. So I think those kind of things would have been in the product shift, as well as if we had some, for example, if we had a new medication, come out and had a lot of uptake on that brand new medication and had seen a lot of costs from that, that would be reflected in the product shift category as well. Does that answer your question? Oh, go ahead, Katie.
I was just going to say that's great. I just want to give one more example too of a negative product shift would be when a brand loses patent protection and that multi-source brand now is not being utilized, a generic is utilized instead. So that's another example to your compound.
Thank you. Always good to have a little more context in there. Did that answer your question, Robert?
Yes, thank you very much.
Mm-hmm. I do think it's good to spend just a few moments on the unit cost impact, and initially we thought, wow, that would really go up as we had specialty drugs, but I like the way that it's characterized in here because it really reflects how the price of specific drugs have changed. And here we can see that each of the drugs really has not changed a whole lot. We have a very low impact from a specific drug increases, and you could almost kind of think of that on the medical side as, hey, how has my cost per visit changed in a sense? And so from looking at individual drug prices from one year to the next, we did see that holding low and relatively flat. So, and then the final one, the change in rebates, we saw a pretty big impact from that on our prior slides. That was a 25% increase, which is good for the plan because it's a pass through and ultimately just drives down the cost, the premium cost, which is beneficial to all of our members and entities as well. So any question on the MODA trend drivers before we take a look at the Kaiser? Okay, so Kaiser, again, we mentioned does not focus on rebates. That's not a large part of their strategy. And so, we don't have that categorization. And, frankly, the Kaiser, trend components are sort of more boring, but in a great way. We're seeing all of those three categories being relatively flat, low utilization impact, a flat unit cost impact, and a product shift impact that is even a little more of an offset to the utilization that's driving that 0.5 point reduction. So just very good results across the board from a trend driver perspective, all categories performing well, and just not a lot of comments on that one other than just really good results in that. Any comments on the Kaiser before we move on? All right, so we can move to slide 12. This we take a quick look at specialty medication and just really what portion of the cost they're making up from the prescription drug side. A couple interesting observations. We have MODA on the top and Kaiser on the bottom. And for MODA, we're seeing the MODA distribution of costs. We have traditional kind of the yellow with the circles, and specialty costs is the green with the diamonds. And this is the typical trajectory that we've seen, from a more national basis. This is a very typical graph where we see traditional starting out at a much higher proportion of the drug spend and gradually decreasing while we see the specialty starting out low and going high. And so we're ending at just about a 60-40 split. We've got 58.8% of prescription drug costs are now specialty, and 41.2% are in the traditional category. And that's a change from last year where we were at more of a 55 specialty and 45 on the traditional side. So, best in class we're seeing right now is right around the 50% mark. I will say that number is a moving target. That number has been changing quite a lot over the past few years as well, very similar to how MODA's distribution has been changing. On the Kaiser side, the first thing you'll notice is that we have a pretty big, we have some ups and downs on that first year from 16-17. That does reflect that reclassification. And we'll see that, you can see that in the last note in the bullets there. But after that, we've seen the cost distribution remain relatively flat. So no matter how you're categorizing it, we go down to that lower green line, and specialty costs were pretty flat from 17-18 to 18-19, and just a small uptick from 18-19 to the 19-20 plan year. And correspondingly, the traditional category, even though it may include some specialty drugs that would traditionally be categorized as specialties, such as the Humira and the Enbrel, has also remained flat over time for the last 3 years. Any questions on that? All right, so we'll move on to slide 13. And this is just a quick look at our average cost per script. So this is the average medication cost that we have in there. We've seen there's a lot of stuff going on here. So we've got some lines and some bars. As a quick orientation, the top line that we see, which is sort of the blue circle, is going to represent the total cost. It's the sum of the bars, both the purple and the gold bars. And the bottom line is our member cost share that's on a percentage basis. And sprinkled in there, the bars represent the total cost of the medication, with that little top section being the member cost share on a per member per month or on a per script basis, and the bottom being the plan cost. So we did see an increase of just about 4%, I believe, going from $83 to $86, almost $87 on MODA. From that, we actually saw a much larger increase in the member cost share from $11.22 to $12.70. That was about a 13% increase. And we saw a small, correspondingly, if we have a higher member increase, then we saw an offsetting lower increase on the plan paid part of that script from just about $72 to just about $74. And then in the bottom, we see that corresponding member cost share, which has hovered right around the 15 mark, went down a little bit, in the last 3 years, and now back up a little bit to 14.7% in the current, or in the last plan year. Just for kind of best in class reference, that best in class or target member cost share is hovering right around the 16% range for the marketplace in general. For Kaiser, we see just a little bit of a drop in that average cost per script, going from $46.44 to $45.53. That's about a 2% drop. And we did see a corresponding 2% drop in both the member portion of the cost share as well as the plan paid portion of that medication cost as well. So no real changes there, no surprises or changes in distribution. And then we saw just a tiny downtick in the member cost share from 10.7% to 10.6%. All right, any questions on that before we move to our generic utilization rate? All right, so in this chart, we go back a number of years.
Brad, this is Tom. We have 10 minutes left.
Okay. So we'll go ahead and thank you. That's a great time check. And we'll go ahead and skip that generic. We kind of touched on that. The only comment I would make is that MODA's done a great job of gradually increasing, and Kaiser has done a great job of holding very high over the last 5 years. So both best in class. And so with that, we'll turn it back to David to talk us through kind of things to watch and what we should be thinking about looking ahead.
Perfect. Thank you, Brad.
Mm-hmm.
We'll go to slide 16. And I'll just hit this slide pretty quickly as well to be cognizant of time. The one big thing here is that the way that MODA, this incorporates medical pharmacy. So that's really the intention of this slide here, to incorporate drugs that we haven't seen on the medical side being added in to contrast how it looks compared to a pharmacy specialty. And that can be seen with the MODA medical RX is a purple line with the square box. And then the traditional specialty, the pharmacy specialty that we've seen so far, is that green line with the diamond, if I get that correctly with my shapes. And so one of the big things that we wanted to highlight here was there was a shift of the medications on the medical RX side shifting over to the pharmacy specialty side. And I hope I said that correctly. But when you combine those two, because some of the medical drugs are now on the pharmacy side, the overall increase, though, is actually not that high. If you combine those two, the per member per month cost ends up being about $89 per member per month. And the change from the prior period to this year is about a 3% change, so not that significant. If you do the same thing and contrast that with Kaiser, the medical pharmacy being in yellow and the pharmacy specialty being blue, when you combine those two, the prior period compared to the current period actually has a bigger increase. It actually changes to about $27 per member per month and about a 7% increase. So those are some things that we wanted to highlight that you probably haven't seen too much, but we think it's helpful and beneficial to see that there are still drugs on the medical benefit side. So that's the take-home message from here. Even though we saw an increase on the MODA specialty pharmacy RX, there was a decrease in the medical side. So I'll pause for a quick moment, and you guys have any questions?
The biggest impact is the fact that MODA is spending 3 times more per member per month than Kaiser is in regards to specialty drugs when you combine the pharmacy and the medical. 3 times. So that we need to understand that
Sure.
Much better.
No, that's a great observation, Tom. I will highlight that right now because one of the call-outs that we had on the Kaiser plan was that a good proportion of specialty drugs got moved to the preferred brand tier, which isn't incorporated into that.
Okay, that's right. I remember now. Right.
Yep.
So that's another impact, but it's still, again, we need to understand the differences between those two, and affordability is top in our mind within a context of people getting appropriate care. So we're going to need to understand that to a greater degree.
For sure. Yeah.
Okay.
Remind me, we end at, is it 10 o'clock or is it 10:05?
10:05.
10:05. Okay. So we have 12 minutes. So with 12 minutes, we have just a couple more slides left in this deck. We did want to highlight some pipeline medications, and what I'll do is I'll just highlight the most expensive ones on each page. So the one I'm going to highlight here on page 17 is the ionofarnib, which is for progeria. If you see that one, that's $500,000 in estimated annual cost. The condition for this one is a breakthrough type condition. It's basically a child who's been diagnosed with this progeria disease. And what it is the kid rapidly ages. Imagine a child aging 8 times faster than a normal, than a traditional, non-impacted patient. So, by these type of kids will live to maybe age 15, age 17, and even by age 4 or 5, they'll have looked already aged and maybe more in their geriatric type. So this drug is considered a breakthrough to help with quality of life and enhance the overall the length of life, but it isn't a cure. So $500,000 is per year, and it's helping to increase their longevity overall, but not a curative to that condition. So that's the one I want to highlight. I'll move on to page 18. And so with 18, the one big one to certainly that you can see is there's certainly more cancer drugs. If you look at the majority of the drugs that are on the top, few lines, there's certainly a lot of cancer medications. We know that there's new novel type drugs and treatments for cancer. So that's certainly coming down the pipeline, but also comes with an additional cost as well. So that's a takeaway message with that. And then you'll see also there's an Alzheimer's drug, and that actually got some headlines, I believe, yesterday, just needing additional details. It was initially supposed to be maybe not going to pass the FDA, but with additional requests of information, it looks like there may be some success in getting approved on the market, but that's to be determined. But Alzheimer's, there hasn't been new drugs on the market for the past 20 years. So seeing some new medications for Alzheimer's, that's certainly something to watch for. So we'll go ahead and go to slide 19. And with slide 19, the real big one is these are the gene and cell therapies. They're quite expensive, as you can see, ranging from at least on the minimum of $300,000 on this list upwards to $2 million. So those are the things that we're seeing. We want you to be aware of, and a lot of these are one-time infusions. One infusion could certainly it could help mitigate disease, but we want to also call out that even though it's a one-time infusion, it may not be fully curative, but help to certainly make a big impact in the disease progression. So a lot of different conditions now. The child X-linked adrenoleukodystrophy, that's a brain condition. So those are some things that didn't have any treatments in the past, and now with these type of therapies, certainly making a big impact in treatment. So that's just what I wanted to highlight on slide 19 and be cognizant of time as well. Any questions so far on the first 3 pages? Okay. And I'll go to the last one, which is another big topic that we wanted you guys to see, which is gene therapy, but now for hemophilia. We've heard about hemophilia. We know that it's a bleeding disorder. And what this is you're seeing the immense pipeline that's coming out for hemophilia. And these drugs are also not curative, but they're helping to mitigate the severity of hemophilia, both A and B, A being the most common, about 80% of the time, and B being a little bit less common. It just has to do with the clotting factors for each one. So B is about 20% incidence rate. And what this is here is we've seen hemophilia drug costs for each member ranging from, less, maybe if it's a good year, can be less than $500,000. If it's a severe year, it could range from $15 to $20 million, for treatment and hospitalizations for one member. So having these drugs isn't going to cure hemophilia, but what it is it's to help mitigate that type of severity and needing to go to the hospital for those rescue or treatments for hemophilia. So we wanted to let you guys see that's certainly a big topic. And next year, as we come back, certainly it'll be maybe sickle cell, other new genetic conditions that are prominent that haven't had treatments in the past. That'll certainly come. That'll certainly have new therapies on the market. So that was certainly the biggest one I want to highlight. Okay, Brad, did you want me to kick this one over to you for the management and approaches and to close it out?
Yeah, I think that sounds really good. You know, this is really just more of some continuing documentation on slide 22 here. You know, very similar to what we've seen in the past. I don't think anything we need to spend a ton of time on. So we can really move to slide 24, which is just sort of our more general opportunities slide. Just a couple on here that we've got that, you know, we identified for the upcoming plan year is to, you know, continue thinking about our second step for that oncology site of care for our upcoming renewal. And then, you know, we always want to make sure that we're focused and diligent about looking for our pricing terms within the OPDP contract. We want to make sure that we're properly capturing and that the contracts are recognizing the expected rebates that may be available to the plan to, you know, help reduce those costs as we transition from the medical pharmacy side to the specialty pharmacy side. So we want to make sure that we're capturing those. Just something to, you know, more due diligence on that. And then finally, we probably feel like we need to look at the timing and cost impact for the upcoming move to Navitus, which, you know, I think could be effective as early as 1/1/22, I believe. So kind of looking at that.
Brad, have you been given any estimated impact?
No, we're working with MOTA on that. I think that is still on the MOTA side, still a little bit in final process.
Okay.
Last I heard, we were going to maybe get some of that in potentially the early April timeframe. I'd have to go back and review my notes for, you know, to get that for sure. But yeah, that's something that we did talk about. We met with the MOTA pharmacy team and had a pretty good discussion on that. Where the weeks really slipped by. I think it was last week or the week before. So
did you see? You want to ask your question?
Oh, pardon?
Bill Gropp, you sent a question, Bill.
Yeah, I know we were running out of time, so I just wanted to
that's
type
cool.
it in there. But,
No.
I was just wondering, you know, in the case of, you know, what Tom was asking about earlier, you know, how can a regional program compete with a national program on bargaining for RX pricing? It seems kind of impossible to me.
Well, you know, I think that, and you know, MOTA can certainly speak up, but you know, these are not just, you know, like an organ player. These are larger players in there, and I do believe that we, you know, the OPDP is you know, pretty aggressive in their contracting, and I believe that this covers not just a commercial population, but other non-commercial populations as well. So I'm not an expert on that though, but you know, I think those during the RFP process, that was, you know, the financial impact was evaluated. I think we did have a pretty good improvement, or there were improvements in the guarantees for the various contract terms.
So Brad, isn't it true that the current PBM and the one that MOTA's going to are both national PBMs?
Yes. Yeah. So it's like I said, it's not just a specific organ focus.
And my guess is that the biggest problem is not the cost of the prescription for the you know, the generics. You know, 9 out of 10 are, you know, the costs are managed and there's not any significant. My guess is that the biggest difference has to do with the costs that are added when you get people doing their own infusions in their medical offices or in hospital settings, and the base cost of the drug is inflated 2 or 3 times, where a closed system like Kaiser Permanente doesn't have that type of profit motive that's kind of built into it. Now I'm kind of making that up, but I think that there's something behind that part that starts explaining the differentiation that we're seeing.
Yeah, and I'm sure that is part of the story, and I think that's why we started, looking at that site of care initiative.
Right, very important.
Yeah, and we're already seeing the initiative for the gene and cell therapy, so there's opportunity to ensure that there's the highest quality, lowest cost opportunity. So almost a centers of excellence type opportunity with gene and cell therapy. And so those also complement a value-based agreement. We're certainly wanting to hold those pharmaceutical companies accountable for that as well.
Yeah. Makes a ton of sense. Okay, well, we've hit our time. Any other committee members have questions? I would like to thank Brad and David. Very helpful presentation, to the point, and this is one of the meetings at CIO that I always look forward to, because at the end I feel like I've learned so much. And also thanks to our medical plans for working with our consultants putting this all together. With that, I think we move on to our next topic, and that is transgendered benefits, and we have an attachment for that. Jenny, are you going to introduce this, or is Taylor?
Yeah. I'll start us off, and then I think that's a good entry or entree to introducing Taylor. So I think, Taylor, you want to let us know that you're on?
Yep. Hi, everybody.
So just, many of you, I don't know, have met Taylor before, but so Taylor has been with Willis Towers Watson for, is it 6 or 7 years, Taylor?
Almost 6 years now, yep.
6 years. And she's been part of the OEB team for about 6 months now. So getting to know all the nuances. So, and Taylor put together a lot of the information that's in this presentation. So, but I'll just go ahead and kick us off and explain what, why we're talking about this. I mean, the one of the reasons that we started to explore this in depth is that MOTA has proposed adding coverage for a specific service, and that's gender confirming facial surgery in the OEB plans, as specifically for members who are transitioning genders. And so we thought it would be a good idea to just take a step back and take a look at what are the general guidelines and recommendations out there for covering a variety of healthcare services for members who are transitioning genders. And then we'll kind of take a look at what are the carriers currently doing, either for OEB or PEB or their book of business, and then perhaps even what the CCOs are doing. Maybe just to add even a little bit of more context, I can remember, I'm going to say like 8 years ago, where it was very rare that any services at all were covered. And a lot of members who were looking to transition genders, a lot of times would get those services covered overseas. And so there's just been a lot more attention and focus on trying to care for and support, all kinds of members. And so over the years, there's been, an expansion of coverage. And so we'll talk a little bit about that. In fact, so on the next page, we'll talk about the WPATH recommendations, which is one of the more premier agencies that takes a look at that. And I'll go ahead and toss that to you, Taylor.
Perfect. Thank you so much, Jenny. And thanks everybody for having me today. Excited to start taking part in these meetings every month. So as Jenny mentioned, we just kind of wanted to provide a little bit of background about what WPATH is. And what that is essentially is an organization that is supported by multidisciplinary backgrounds. We've got professionals from the medical community and from all kinds of communities that really focus on promoting that evidence-based care for transgender individuals. They look to advance public policy, support research and education around taking care of the whole person. And they also publish their standards of care and ethical guidelines, which is essentially a document that really is kind of a consensus of the standards of care for individuals going through gender dysphoria and managing possible transition. The WPATH standards of care are widely accepted and supported by a number of professional organizations, just a few listed there on the slide. The American Medical Association, American Psychological Association, among many others. WPATH guidelines are not federal requirements, they're not legislative requirements, but they are kind of viewed as best practices. So since they're not legislatively required items, not all plan sponsors necessarily cover all items or align. So differences can exist between plans and sponsors. And the differences there really could be because of a difference in evidence-based practices. There can be a balance of cost and coverage taken into consideration. And then also we've seen case law pop up in other states and areas where it may inform opinions or actions from other plan sponsors. Any questions on that before I move forward? Okay, so we also just wanted to provide kind of a brief history lesson of kind of what transgender healthcare has looked like in the past. It's evolved quite a bit over just the last 15 years. You can see there at the top, California kind of kicked us off in 2005 by banning discrimination against transgender people in any kind of insurance situation. In 2010, Section 1557 of the ACA also banned discrimination against any federally funded healthcare programs against transgender individuals. And then from 2012 to 2017, we saw major moves from the Department of Health and Human Services that kind of reinforced that gender affirming care, from allowing gender reassignment surgery to removing all blanket exclusions for gender affirming care for transgender individuals. So it's definitely a topic that continues to get brought up. It is something we see in the news. We've seen it just recently as a couple weeks ago in switches with the administration. So definitely a topic that continues to come up. All right. Any questions before we move on to the next slide? Okay. So over the next couple of slides, what I'll do is we'll take a look at the different categories that the WPATH standards of care recommends, the different kind of categories of care, and where we see variation between OIBS plans, between the Oregon CCO plans, and between MODA and Kaiser's fully insured book of business. So really kind of those top 5 categories there: mental health, hormone therapy, breast and chest surgery, genital surgery, and then general pre and post-op and preventive and follow-up care are pretty much covered across all of the plans. Where we actually start to see some of the variation is around things like hair removal, facial and body reconstruction, and voice therapy treatments. So if we move on to the next slide, this will really kind of get into the details of each of those categories. So if you just take a look at this from a high level, you can see the X's in each of those columns really indicates that across the board, the Oregon CCO plans, OIBS plans with both MODA and Kaiser, and MODA and Kaiser's fully insured book of business plans all cover these services. So mental health services for the diagnosis and treatment, hormone therapy, breast or chest, or what is commonly referred to as top surgery, and then the components of genital surgery or bottom surgery. When we move to the next slide is where we actually start to see some of the variation between plans and carriers. Anywhere here where you see an X with an asterisk next to it is generally something that may be covered, but beyond just general prior authorization requirements, there may be, for example, electrolysis on the MOTA plan is covered as a component of genital surgery. So it may not necessarily be covered in all instances, but may have some additional specific requirements. I'll kind of point your attention here to that third category down, which is that facial reconstruction category, which is kind of the big purpose of this conversation today. And you can see there on the left-hand side, the CCO plans today in Oregon don't cover the components of that facial reconstruction. The OEB's MOTA plan today does not cover those components, but the OEB Kaiser plan does cover a number of those procedures under that plan, as well as the fully insured book of business plans for both MOTA and Kaiser. And then if you just drop below that, you can see it's pretty much a consensus across the board that the body reconstruction and contouring is generally not covered across any of the plans. Voice therapy tends to not be covered, and there's some, again, some special requirements around that if it is to be covered. And then finally there, that last category is kind of a catch-all for your pre-op, post-op, preventive, and follow-up care that is acknowledged as very important in the process and covered by all the plans that we're looking at today.
Question.
Yeah.
In the facial reconstruction category, if MOTA covers these through their book of business, are they excluded in OEB?
I believe today, yes, the components of the facial are excluded from the policy.
But yeah, MOTA just recently started covering the facial surgery for their book of business. I'm just going to say in the last few months, so it's relatively new.
Yeah, that's correct, Jenny.
Yeah.
So do they expect to include that with OEB at the next renewal?
Yes, so we have proposed including that at the next renewal, and if we actually fast forward here to the next slide, we can see that MOTA has provided a pricing impact to cover those, to cover that facial confirming surgery at about 0.2% of premium.
Okay, thank you.
No problem. And then obviously, as we saw on the previous slide, Kaiser covers a majority of the facial confirming surgery components, and they do follow their own clinical practice guidelines when determining their coverage alignment. And then kind of Jenny alluded to it, but one of the reasons this is recently being proposed by MOTA was based on some codes recommended from the International Facial Gender Symposium for coverage of these services, and then also to identify a legal risk that was seen in another state. Questions there? All right, so I think that
I don't know that we went so far as to put in the recommendation, but the MOTA proposal, we'll talk about that at the renewal discussion this afternoon. But obviously the coverage, or maybe not obviously, but the coverage proposal by MOTA should bring them into alignment with their book of business with Kaiser, and is generally recommended.
Yeah, so this is Tom, and these types of increases or changes to plan coverage are dealt with by the board. I think the board appreciates a recommendation from CIAO in regards to what we view as the evidence, whether or not it's evidence-based treatment. And so while whether or not we can afford adding 0.2% to the MOTA renewal, I think again, that's the board's decision, but our discussion and recommendation should be based on what we view as the is this appropriate to add in terms of coverage. And Jenny, what you've just said is, one, that it conforms with the rest of MODA's book of business. Two, Kaiser Permanente is already offering those services. Three, it is recommended by this best practices organization. And four, there were some legal risk that was associated with it. I'm not hearing anything that says it's not appropriate from a medical standpoint. Is that accurate?
Yes. Yes.
Okay. So I guess what, as I'm going to be presenting or bringing this forward to the board in the CIAL update, and obviously it will be included in the renewal presentation by our consultants. Does the committee suggest that we should give a thumbs up to this?
I would just add, Tom, that the PEB board is also considering this in their renewal, which is also getting started this month. But they've kind of been talking about it in a previous meeting and getting their benefits up to the WPATH standards wherever possible, and at least getting it aligned with the book of business for our carriers.
Great. Okay. So that's another. I think on the positive is the consistency that we're seeking between OEB and PEB. Any additional thoughts? Go ahead, Robert.
Yeah, Tom, are we only talking right now on recommendation for the 0.2 for facial reconstruction, or are we going broader?
I think it's only that. I think what the proposal that is going to be advanced is the addition of the gender conforming facial surgery and all the issues that are associated with it. It's more, I think it's more than surgery. There was in the last one of those slides, it showed multiple things that were part of the process.
So one more thing, compliance is another issue, of course, and that's usually automatically put in. Are we aware of any pending legislation, or both state and federal, that would require this? Which makes it a no-brainer if that's the case.
Yeah. Taylor, your thoughts on this?
We've not heard of anything coming down the pipeline that is going to be mandating the facial confirming surgery, but certainly I do think it's important to consider that there has been lawsuits brought up about it, and I imagine that there will probably be more attention in the future on it.
Okay.
Is Glenn on the line? Glenn Bailey?
He may not be. We do see most of the bills that come through that are related to healthcare, and so I haven't seen anything in this upcoming legislative session, but it doesn't mean that it won't come forward, in future years, because you just maybe, as Taylor kind of walked through the history, there's just been a growing understanding that these services are needed and helpful to help folks really make the most of their transition.
If we were all sitting around the same table, I'd be asking committee members to give a thumbs up or down. So I guess we have to do that verbally. My thumb is up.
Yes, up.
I'm good. Thumbs up.
Okay. Jeff?
Yes.
Okay, thank you. So anything else in this subject that from Taylor or Jenny?
Not from us, unless there's any other questions.
Okay. Okay. So we were able to get through that a little faster than we thought we needed to. I have that it is 10:25, and I'm going to suggest we take a 10-minute break and restart at 10:35. Alrighty? Okay, very good. Thank you all. We'll reassemble in a little bit. Bye-bye.
Robert. Mr. Young. Oh, you don't have your headphones on. Okay.
But I do.
Is that Bill?
Yes. Making another cup of coffee.
Yeah, I just got back from the kitchen. So did that answer your question on the pharmacy purchasing?
Yeah, it's a complicated thing, right?
Oh, yeah.
You know, you look at the difference in the chart, and if you don't really been listening for the last 3 years, you know, it's just like, oh, what's wrong? And, you know, Tom correctly points out that, you know, we need to understand that a little deeper. But there's a lot to it. It's not just what the chart says, right? So.
Oh, I've been listening for 10 years specifically to OAB, and it's still more things come to light.
I've heard some comments about healthcare costs, you know, at the legislature as these bills are rolling through their first rounds of committee, and it's just like it's not quite like that, you know. And
no, true. It's I don't know. Since we have the microphone going, I'll be discreet.
Hey, Jeff, this is Glenn. Sorry, I got muted earlier for some reason. You had asked, is there any bills in regards to the facial surgery? No, yeah. I haven't seen anything this session. So,
okay.
But I think it's good that we passed it because there is a big push for health equity.
Right. So under the umbrella, we'd be conforming.
Yeah.
Oh, so Robert's got his ears back on? But you're muted.
So yes, I can hear you now.
Okay. Just as a sidebar there, we're putting together another COVID discussion roundtable. And I can't make that time, so you'll be the OAB representative, okay?
Sure. Yep, not a problem.
I can't make it either tomorrow. So thank you, Robert.
Oh my goodness. So even more pressure on you, Robert.
Well, if only that were true. So I don't think there's going to be much pressure. I think everything is it's kind of out of our hands. We're just more of a sounding board at this point.
Right.
Right.
You just need to make sure you've got two hats so you can put one on and back and
Or
forth.
two faces. Yes.
And Uncle.
Okay, it is 10:35. I heard Robert and I heard Jeff. Bill, are you there?
I'm here.
Perfect. So we are ready to move forward. And our next topic is going to be OEB wellness programs. Pardon me. And Jenny, you're going to lead us off.
Yes, I will walk you through these, but I was glad to hear Glenn's voice on there because Glenn is pretty familiar with these vendors as well. So what we'll talk about today is just OEB's wellness vendors and take a quick look at utilization, costs, and with the background of helping PIAO make a determination about whether to continue these programs into the future. Okay, so we'll do the executive summary and then we'll look very briefly at each one of the programs. So the executive summary, really, we're just listing out the cost of each program. Oops, go ahead and go forward. Yeah, the cost of each program in 2019 and 2020, for the 2019-2020 plan year, you'll notice the costs on the right-hand side for the current plan year are for the most part yet to be known, because a lot of these programs, the cost for them is based on the utilization. And so obviously we're still in the year, and so we won't know what the utilization necessarily is going to be. For a number of these, and we'll talk about this on the next slides, but a number of these programs did see a reduction or a decline in engagement or participation. And, a lot of that may have been due to the pandemic and folks either not engaging like they normally do or having other priorities or whatever. So we'll talk a little bit about that. And we'll take a look at engagement in some cases over the past couple of years. Okay, let's go ahead and move forward. So we'll talk about, better choices, better health, which is the chronic condition management program. It's primarily an online support group for a variety of different chronic conditions. And Better Choices, Better Health, or Canary, has come to CIAO and presented, their program in detail. I think it was back in December, so we can go back and look. But just to recap their pricing is based on how people participate at certain milestones. And so for this particular program, you can kind of see, the engagement was a bit higher in the 2018 plan year, and it did decline for 2019. So just something to be aware of. We've got a note down there that while there was a reduction in engagement, we do tend to see these digital programs for many of our other clients increase during the pandemic as people were seeking out other digital support programs. So, it may be, again, that folks were either not aware of it or had other priorities that they were focused on. Any questions about that? No? Okay, let's move to virtual lifestyle management, which is essentially a diabetes prevention program. This program, has had some pretty good engagement in the past. It's primarily, again, an online sort of digital program for members with diabetes or preventing the diabetes. And so what you kind of see here is that engagement was higher in 2019-2020 for this particular program, although we're not 100% comparing apples to apples because we had slightly different milestones that we were measuring back in 2018. But overall, it does look like the engagement was higher. this is a program where there's a variety of different resources through the carriers as well. As you may know, MODA recently just put in a diabetes prevention specific program, and then Kaiser has its own program as well. So there's a little bit of duplication, so it's, I think, prudent to continue monitoring this one.
So Jenny, I would, my thoughts about this one are exactly dovetailing into what you just said. Both KP and MODA offer services in this regard, and they MODA has just upped the game significantly with Livongo. So this one we're paying on a per participant basis,
right?
And what would be helpful, and it's possible that there's going to be an ongoing group of our OEB membership that wants something other than what the two medical plans are offering. So from my perspective, as long as we're offering this and it's on a per participant basis, it will be it's okay if they go to a third option as compared to the KP program or the MODA program. Now, a certain percentage are going to Canary Health, but it definitely should be one where we would continue on a per participant payment structure, I think. The other thing is that it'd be very helpful to hear from and to watch over time how the Kaiser membership is using their program. And I think MODA is already going to be showing us how people are participating in the Livongo program over time.
Yep. Yep. Agree. So it probably really makes sense to continue to watch this for a year to see if folks are continuing to engage this, or they're moving over to
but also to ask that we get, when we look at Canary Health and we, look at participation over 3 years, to be able to look at it in comparison to the numbers of people within the Kaiser system and within MODA's plan, how they're using these services also.
Yeah, yes. And Tom, this is Glenn. I just wanted to tack onto that. When we were talking about this, I think it would be good, since the Livongo just started, to over the plan year of 21 to 22, to look at what kind of participation it gets, and then compare it against the current virtual lifestyle management.
Super.
As well as the Kaiser.
Yeah.
So, Jeff, question, is the cost of Canary a direct pass-through, or is that included in a carrier administration or carrier claims?
It's pass-through, Jeff. It's pass-through that goes then paid out of our administrative fee.
Okay. So,
hey, Jeff, could you explain the difference for me so that I'll know between what you just said?
Be glad to. So, for various reasons, in the past, we've asked some of these programs to be run through our carriers. That way we can avoid doing some RFP work when we've already determined what these programs are. But in some cases, some of these are included in the claim cost. And in some cases, it's loaded into the administration. And in, I think, most cases, the bill goes to the carrier and the carrier issues a bill to OEB, and they just act as a middleman. And so trying to keep track of which one's which.
Yeah, basically they're all subcontracted through our carriers. All of our wellness programs are subcontracted through our carriers. It's just the ultimate kind of pot of money where they're paid out of. In the case of Weight Watchers, it comes out of the claims. I'm sorry, lifestyle management, better choices of health and healthy team, helping you. It comes out of the administrative fee that OEB charges on top of the premiums. But they're all subcontracted through our carriers.
Yeah. This has become a little bit more important as we've been doing some work with our stakeholders group, just to be able to explain where our costs are and put them in the right buckets. So that's why I asked the question.
Thanks. I get it now.
And I don't know whether or not MODA has told us how much Livongo charges on a per person basis. What I'm seeing is with the virtual lifestyle management, the fees range from about $200 to a completion of $800. So while that is a contract that the Livongo contract may be something they're not interested in publishing, it would be nice to hear whether or not the costs of Canary Health's program are ballpark. We don't have to discuss that now, but that would be something be helpful just to know.
Yeah,
So,
I mean, the
while Tom's
here,
bringing that up, I think I know the answer, but I just want to confirm that these pass-through programs, our consultants are negotiating the cost?
No, it's not the consultants so much. It's, really it is the carriers. Well, I mean, carriers and staff. I don't want to, we do have some involvement in it, but at the end of the day, this is done in contract.
So I'm asking why not our consultants, since they're national consultants and they have access to many programs?
Because OEB does not hold the contracts.
Okay, so then the carrier and the consultants can work on this?
When we do involve, yes. I mean, back to, I don't want to say it is the carriers, but we do have staff and to extent the consultants do have some involvement in it.
But literally, we all work together to try to ensure that, OEB is making sure they're getting the best program for the best fees. And, if it's managed through the carrier, again, we work through that, just like we did, with programs like Livongo or the MODA 360. We all worked through that together to make sure it was the best price and program for OEB. And then we just, match that up against what we know from vendors nationally.
Okay, so I'm going to move us along. Go ahead. I was going to try to move us along.
Well, Tom, I'm sorry, to belabor the point just one more time.
Okay.
I would like our consultants to sign off the costs. I think the carriers are in a position where they are asked to administer. And I think staff has a much more limited view or reference as to what the costs are. And I think the consultants should be directly involved in negotiating the cost.
Yeah. That is a, from my perspective, very reasonable recommendation. And it probably is one that would be, board leader to make that decision. I'm not sure if CIAO in particular has Robert and Bill. Do you have any opinion in Jeff's recommendation?
I don't have enough background to be able to evaluate that effectively right now.
Bill, your thoughts?
I'm in a similar situation. I hear both sides of the equation, and I'm not sure which is more beneficial because I don't really understand the underlying detail.
Tom, this is Ollie. I think it'd be best to continue the discussion in board leadership.
Yeah. Okay.
Okay.
Yeah, I think this is a leadership issue, not particularly a CIO issue, but definitely an appropriate one to have. It's just it's the forum that I'm thinking. So in terms of recommendations for Canary Health, what I'm hearing is that we've seen significant participation. It's an area that we know has significant both clinical and cost implications, and we also know that our health plans are offering similar type services. So I think the recommendation is that we continue with this, continuing to watch and see impact in regards to utilization, and have our consultants involved in kind of map the three different entities: the Kaiser Permanente program, the MODA/Livongo program, and the Canary Health one. And we continue to pay for it in a per participant basis. Is there agreement with that?
Okay.
So, okay. So let's go on to the next.
Okay. So Staywell, or WebMD, or as it's also known, Healthy Team, Healthy You, which is sort of the wellness, worksite wellness program and wellness platform. So here's a snapshot of what has been in terms of participation over the last 3 years. And again, the program over the last, I don't know, since its inception in maybe 2013, has been very specifically geared toward and marketed as a work site, on-site wellness team challenge program. And that program has evolved over the years, just based on interest and need. But also over the years, I would say first, Pravada, or who was providing Healthy Team, Healthy You, was purchased by Staywell. And so it's evolved a little bit over the last year or two during that acquisition. And then we'll talk a little bit more about what's happening in the future, because Staywell has now been acquired by a company called WebMD. But here on this page, at least, you can kind of see the participation. And again, this particular program, the pricing right now is based on participation. So if someone actively signs up to do something, then there is a charge. So, I mean, essentially what that means is the more people who participate, the higher your costs are going to be. And then if you don't have very many people participating, you have low costs. So the goal of that model is to place incentive on the vendor to really drive enrollment. But what you've seen here is over the last year, the participation has really dropped. And some of that may be because there's not really, people haven't been on the work site or on school campuses. So there may be less visibility into this particular program, even though they can sign up online. Do you have anything else, Glenn, that you'd want to?
Yeah, and the other thing too, this last year, some of it's been COVID. The other issue too is, and also the reason why you saw the drop in the cost, is that they don't provide as part of the program. Originally people, for Healthy Team, Healthy You, one, you get an activity monitor. Two was you get stretch band, and then three they get a blood pressure monitor. All of that has been discontinued. A number of reasons. One was there were issues with the monitors, and they were being made in China, and there were some safety issues that they had to discontinue with that. There was also, they gave us a price break in the last year because of the timing of the discontinuing, which is why you're seeing a lot of the drop off in the cost. So instead of the normal $84, they took us down to $67 because of the timing and some of the disruption that happened over that. So that's why you're really kind of seeing, I mean, I think you really have gotten away from those items. They weren't really connected to the system, and there were a number of issues that really led to that, but just to add some context to that.
Okay.
So Glenn, we're paying on the same per capita cost through 2021, is that correct?
We are paying, yes, through 2021, we're paying on this $67 right now.
Per participant.
Yeah.
Okay.
I'm just kind of in favor with
so.
Tom that our favorite approach is to do it on a per capita basis.
No, a per capita or a per participant?
Per participant, excuse me. Thank you.
Yeah. They're going over to, and Jenny, I don't mean, can we go to the next slide, I believe?
Go to the next slide.
Yeah, let's get the next slide.
They're really proposing a new pricing structure.
Okay.
Yeah, and this is, they're going over to the WebMD platform. The platform, unlike before, it doesn't have the three specific programs where you could say a person is going through Healthy Team, Healthy U1, Healthy Team, Healthy U2, Healthy Team, Healthy U3. It used to be they just got charged when they signed up for those programs. Here, what you're getting is a per a PEPM, which would mean that it's all based on our eligibility. It's the same process that Weight Watchers is using. And because now you don't have those three programs, you have all kinds of resources, and both, smaller programs, videos, all kinds of resources. It's more like a platform. And so they're giving us for a whole year, here's your PEPM cost for anyone to do it. So it's really, you can no longer say they're going through this 12-month program anymore and doing it. That's why it's very much the same, similar, but that's what Weight Watchers does for us. They're giving us a global budget and saying, based on a number of factors, eligibility, performance, things along those lines.
Yeah. But Glenn, the difference between Weight Watchers and Healthy Team, Healthy You has been and its iterations have been that with Weight Watchers, we've seen a very consistent utilization. And I'm looking at slide 5 or 6, and I'm seeing, 2,800 one year, 3,500, 1,300 the next year. And with that type of variation, a cost per employee seems to be not the right way to pay for it. Now, I get what you're saying is that it's an access to a web-based system that people can pick and choose various parts. I don't know whether or not that means they're going to be able to even to tell us what utilization people are using, what our OM membership are doing.
No, they'll be able to provide reporting. So I just to add a little color. So the $3, so the new pricing structure that they've proposed is a year. So it's $3 a year assessed on all members, but really it's just a flat fee. And that means members can use it whenever they want. There will be reporting on those who, take a health assessment and go through the different programs or healthy habits or challenges, pros and cons, right? So there are some similar services or resources available through either Kaiser or MODA, but you have to be a Kaiser or a MODA member to access them. So that the idea behind a wellness platform for all is that, number one, all eligible OEB members, even if they're not enrolled on a medical plan, would be able to access this. And, it's the same experience if they transition from Kaiser to Moda and the other, and vice versa. So,
well, Jenny, let me just add, they still have to be enrolled in a medical plan to use this.
Sure.
And those that eligibility that they're using is eligible medically enrolled people.
Okay.
So go ahead, Jeff.
2 years ago, I believe, I think it was the consultants did a crosswalk of all of our programs, and we did a pretty big global look at our wellness programs. Moda has made some changes. Probably Kaiser has. Obviously, Staywell WebMD has made changes to their programs. Could we ask for an updated crosswalk as to see how much duplication we have? I mean, it's not purely duplication because, some people respond to different programs other than others, but with enrollment in that, is this program necessary going forward? Is it engaging enough people? And my concern with this program in the past is they onboarded a number of people at the annual wellness conference and on site, and people signed up to get the pedometer and the other. And then we weren't seeing, as I recall, a lot of evidence that much happened after that. So I have concerns.
Yeah, and if I could just continue kind of with the pros and cons, and Jenny, please jump in on this in regards to pricing structure. And, of course, the pro is that you're seeing a very steady, even if you had an increase in participation, you wouldn't see a real increase in the costs so much over time. Of course, the downside is if you do see a drop off in for whatever participation, you're still paying that. That could be for negotiation. I mean, that's in regards to this program, it's getting to what you're talking about, Jeff. Yeah, there was, but they have gotten rid of all of those items like the activity monitors and that kind of thing. So you're really getting down to the people who this really benefits. And there is a lot of reporting that, like they did in December, about, the pre and post. And so it's a much there. I think there is some duplication, if you talk about, the different conditions. But there, as far as I know right now, well, I don't want to say, but the point being is, I think that is a good thing to do over the next year, is to look at it, do an updated crosswalk.
Yeah, I think philosophically, we can afford to offer more choices when we're paying on a per participant basis. But when we're paying on an eligibility basis, we are adding costs on top of costs on top of costs. And we need to ensure that we're getting value for that.
So Robert or Bill, do you have any points that you want to add to this?
No, not right now.
No, I'm in agreement with what Jeff's pointing out here.
Okay.
I'm just letting him do the lifting.
Sure. So I think what we're hearing for Glenn and for Jenny is to go back to WebMD and express our concerns about this up and down in regards to participation, and that we are, during times of that type of volatility, a per participant payment structure would be better than a per employee per year basis, particularly when there's significant duplication.
Why don't we, with the carriers, and go back and see if we can get them to do some type of per participant cost structure.
Okay, super. That's otherwise. I mean, I think that it's what we want. The things that are offered through this program are things that are appropriate and important from a wellness standpoint. So it's not that we're not in favor of what they're doing. It's that the uncertainty around participation makes us want to fund it in a way different than what they've just talked about. So with that, let's move on to the last one. We've got 5 minutes left, and I want to go ahead and wrap up because we've got a whole lot of other stuff to do.
Well, this one's very easy because it's Weight Watchers and Curbo, and I mean, they recently just presented what their activity is, and here you can kind of see that it's at just under 6,000 active members who are participating, but they do have their price structures on a flat fee, but they're not proposing any change to that for the new year.
Issues or concerns from CIAL members?
No.
Okay. Jenny, your last slide is recommendations.
Yeah, I mean, at a high level, the recommendation is to continue these programs as outlined on the slides before. But what it sounds like is what I'm hearing is you need a little more information or a different potential pricing structure on the wellness platform.
I think that was the conclusion. That's what I heard was we're interested in continuing these. The only issue has to do with the payment structure, pricing structure for the Staywell WebMD for the reasons that we talked about.
Yeah.
Okay. All right. Any other thoughts from committee members? We'll move on. Okay. Last topic is 2021-22 benefit and program recommendations from MODA. This was a separate set of email that came out a couple days ago.
Great, thank you. And Rose, should we just say next slide when we're ready for the next one?
Sure, that'll work. That's fine.
Thanks. Thank you, Rose. All right, well, thank you everybody for having us here today. We want to talk to you today about some enhancements to MODA 360 that we're proposing for the upcoming plan year. And today with me, I have Dr. Robin Singh, our Chief Medical Officer, Bill Dwyer, our Director of Analytics, and also Dr. Terry Barrichello, our Chief Dental Officer. So before we get started talking about the specific proposals, first I just want to give a really quick reminder that we did implement MODA 360 for OWEB members effective October 1st of 2020. And MODA 360, as a reminder, is a partnership with OWEB to evolve the coordinated care model. And we've been partnering with OWEB for several years in bringing coordinated care to OWEB members, and MODA 360 is really just evolving that model. We had a successful launch of MODA 360, and at a very high level, we implemented a brand new health navigator team to help members navigate the sometimes complex healthcare system. And then we also implemented a few point solutions that are integrated into MODA 360. And that was Cirrus MD, Livongo, and Maru. So today we'll be talking to you about some proposed enhancements we have to expand on the MODA 360 platform. And these are really aiming to provide OWEB members with better health, better care, and lower costs. So really just evolving that full care of the member. So first, we want to talk to you about a program around chronic kidney disease. So I will pass it over to Dr. Robin Singh. So Rose, 2 slides ahead now, please.
Thank you. Good morning. Robin Singh, Chief Medical Officer, MODA Health. Chronic kidney disease, incredibly frequent, more than 10% of adults, and increasing in prevalence, including younger adults, and very much significant health disparities involved. Very high cost, the human cost, 25% mortality rates approximately for those on dialysis, so late stages ESRD, and where a kidney replacement is required. It's a top 10 leading cause of death, and approximately $100 billion spent per year here in the US on CKD stages 1 to 5 and ESRD, almost always progressive and permanent. It is highly complicated. There are multiple comorbidities for the vast majority of patients, and that includes cardiovascular disease, which is often actually the cause of death. Sadly, retinopathy, neuropathy, so multiple systems affected. These patients therefore have multiple needs. The acute decompensations of their chronic conditions, behavioral health impacts, depression, anxiety, and other elements are extremely common. They have very specific dietary requirements and socioeconomic impacts. It's obviously difficult to maintain some forms of employment, for example, if on dialysis. Next slide, please. Some of the key issues to address to improve chronic kidney disease management: earlier identification of those at risk, and of course prevention of progression across the stages from CKD 1 to 5, attempts to address the high morbidity and cost that we've heard about, a lack of information reaching patients and members, education that's required around preventative factors, around their various conditions, around treatment modalities, and having them really prepared in advance to avoid elements such as crashing into dialysis. The current system drives members into high-cost in-center dialysis as well. So we intend to partner with a vendor expert in this space to enhance our current services. These models typically offer analytics enabling earlier identification, specifically predicting the onset of chronic kidney disease, and predictions around those at most risk of end-stage renal disease. The vendor models, through a variety of interventions, offer a slowing of the progression of the disease. Care coordination is a key element as well.
Dr. Singh, this is Tom. A question. My understanding of most of the early identification is based on ability to monitor lab tests, specifically creatinine. And I don't know whether or not MODA has the actual creatinine levels to be able to do that. I mean, I know that through a claim system, you know whether or not someone's had a creatinine check, but I don't know whether or not you actually have the value to then to be able to do the early identification. Could you address that?
Yeah, that's an excellent question. We're mostly dependent on the claims data and don't usually get all of the lab data in real time, but establishing a repository with that type of clinical data and having access to that, and of course sharing that across the network with those who can intervene would be most beneficial in this area.
It sounds like not just beneficial, it's I don't know how you do it without that.
Yeah, and I can add some comments also, Tom.
Fine, thank you, Bill.
Working, yeah, and this is Bill Dwyer, Director of Analytics. So yeah, we're certainly working on collecting as much of that lab data as we can, but there are some of the vendors also have some algorithms that, even in the absence of that lab data, looking at other things on the claims, can use some of their algorithm to narrow in on the population that is at risk.
Okay. Thank you.
Next slide, please. So the benefits potentially here are earlier intervention through identification of members and then appropriate outreach, partnering with the PCP early on, perhaps prior to even involvement of the nephrologists and other specialists, member education in this space, wellness and disease management, peer-to-peer support for members, planning the dialysis transition can make a big difference. We'll hear more about that in a moment. An increased use of home dialysis, multidisciplinary team approach to support these progressions and reduce unplanned admissions as well as readmissions. And this can be delivered via phone or in the virtual setting or at home. Typical outcomes we're looking at then is disease progression being reduced through the stages of CKD, improved quality of life, higher productivity for the member, and a decrease in morbidity, mortality, and total cost of care. And we have some data to share.
Yeah, great. So I'll take over and describe some of the OAB-specific data. OAB had more than 400 members last year that were enrolled at some point during the year and had some form of chronic kidney disease. Right there, we're looking at a chart that shows what stage of chronic kidney disease they had and how many members and what the total spending was. Note that the average cost there is just the cost that was incurred during the year, but since not all members were enrolled for the entire year, the cost per member on a PMPM basis is even likely higher than this suggests. But you can certainly see that, especially as somebody gets to the ESRD stage, and even before that, they're pretty expensive members on the plan. Also, just note, if you look at the number of members at each stage of kidney disease, and it sort of peaks there at stage 3, that strongly suggests that stages 1 and 2, and even perhaps stage 3, that chronic kidney disease is significantly underreported in the claims data. And so getting at Tom's comment about using the lab tests. However, there are some other ways of getting at that, looking at other information on the claim. But that's the idea, is to try to address that gap and get people identified earlier. And this is the population we're talking about managing. So we'll go to the next. Oh,
I
go
have
ahead.
a question. I mean,
Sure.
I'm assuming stage 5 is more severe than stage 4. Any reason why that should cost less on average than stage 4?
Yeah, I just think it's just something weird there with the number of members that we happen to have at this particular time, and that's something that is, and I'll mention later on in the slides too, is that OAB's pretty large group, but even still, the ESRD and advanced kidney disease is rare enough that you get a lot of volatility.
There's probably overlap there between CKD5 and ESRD. So it could just be the way they're classified. Once you're on CKD5, most are often ESRD. So I'd almost want to consider the two together.
That makes sense.
Okay, well, let's go to the next slide. So I want to so this is just to introduce some of the impact assumptions that are in the next few slides. So the program levers that Dr. Singh described are going to help us, we believe, achieve savings in 3 areas. One is to avoid the dialysis crashes. The next one is just general inpatient admissions. We think we can reduce those. And the goal would be to increase the utilization of home dialysis. And so the next couple of slides will address each one of those from a data perspective. So let's go. So in terms of the inpatient crash, here's what your data actually looks like. What you're looking at is a chart with the 0 point there on the x-axis being the month that the member begins dialysis. And so we're looking at 6 months before the start of dialysis to 6 months after. And the plum-colored line represents what happens in most cases where there's not adequate planning that the person is going to have a transition to dialysis, and it sort of comes as a surprise where they crash into the inpatient hospital setting, which is the most expensive possible place to begin and set up dialysis. For OAB members, that translates into somewhere around $80,000 to $90,000 more expensive than it would have been if there was careful care management and planning to all of these members to get them on dialysis starting in the outpatient setting. This is a chronic problem across the industry in getting early detection and care and case management for people who are about to start on dialysis. So if we can get some of these members to have a more carefully planned start of dialysis, there's a pretty significant cost savings per patient for doing that. So that's certainly one of the objectives and one of the ways that you can achieve savings, and also just a better experience for the member. Let's go to the next slide. And here we're just talking about inpatient utilization in general. This population of CKD patients stage 3 and above, where they had $4.1 million in inpatient hospital spending. So, so there's clearly this is a serious illness. It results in a lot of inpatient stays. We think that there's an opportunity to reduce some of that. There's significant inpatient admissions across all 3 of those stages, 3, 4, and 5, many of them perhaps having to do with some of the comorbidities that these members have. But we feel like there's an opportunity to reduce that potentially significantly, maybe up to as much as 20% of some of that utilization with a careful care management program targeted specifically at kidney disease. And let's go to the next slide. And then the third opportunity for savings, as I mentioned, is home dialysis. So there's quite a few studies out there that suggest a cost advantage for home dialysis, something on the order of 10 to 20%. There are indications that patients who are on home dialysis have fewer inpatient admissions. They have lower utilization of other services, drugs, and so forth. Often they'll get peritoneal dialysis at home. It's just, again, even though OEB is a large group, there's not quite enough data in the OEB population because it's just highly variable when you're talking about these very expensive members and a small number of them. The OEB data does look like the home dialysis is also been cheaper for OEB in their experience, but the numbers just aren't super credible, so I didn't really focus on them. And Jeff has a question, yeah.
Yeah, I mean, this is just medical curiosity. I've 2 things that I've heard is dialysis in a outpatient setting, whatever it is, pretty rough on the body. And I've also heard that home dialysis is not as effective. So I'm just kind of curious about the efficacy of those 2 treatments.
Yeah, so patient selection is a critical element, obviously, for home dialysis because they're effectively doing it themselves and/or with carers and support. If with the right patient selection and with the right appropriate clinical support and interdisciplinary team support, actually the home dialysis in recent years is starting to get really good comparative results. You can imagine, though, there are a lot of elements to that, from having the right equipment, supplies, planning it appropriately, the cleanliness required with equipment and so on. And so those elements are not always delivered incredibly well or have not been historically in the home setting. Also, the equipment itself has improved over the years. The programs in the home setting have improved over the years. Given all of those things, today you're starting to see results that are incredibly comparable with the in-center setting. You do have the advantage at home that you can have a longer treatment, so they're actually less exhausting on the body and therefore often less draining and actually resulting in less complications. You don't have the pressure that you have in the in-center setting where it's a 3 to 4 hour treatment 3 times a year for operational reasons and the way it's paid. These are fixed slots, whereas at home they can be a bit longer treatments that can occur more frequently during the week. They can also, in the context of peritoneal dialysis, for example, occur overnight, so it can be actually even gentler. And so you do often get a much better result there. Obviously, if it's overnight at home, typically the member's free during the day and then can remain economically active and have most types of employment, which is often very difficult in center during the day when you have to be there for 4-hour sessions, typically 3 times a week, including all of the recovery times and travel and so on. So that's some of the high level elements. And so in recent years, the home setting is getting very good results in terms of member experience, member involvement in the rest of society, member employment, and even clinical results.
And Jeff, this is Tom. Remember, one of the first parts of the slide, they said a 25% mortality. That's 20 to 25% per year of people who are on dialysis are dying. Now, they also have significant underlying diseases that contribute, but the issue is having end-stage renal disease is a super high-risk medical condition.
Well, it sounds like this advancement of home treatment actually may have the potential of extending life.
That'd be the hope.
And the studies do show different things in different countries and different settings with different patient populations. As you can imagine, delivering the whole dialysis almost yourself at home has its challenges. So the critical element is going to be patient selection. For some people, it's just not going to be appropriate or possible for them to do that. The cost benefits are probably obvious, but having these large centers that are well staffed, lots of equipment, and it's heavier duty equipment, you've got all of those additional costs, transport and so on, and oversight and supervision. In theory, in the home, that's all reduced and minimized, and technology has made that a lot more cost effective.
Good, thank you.
Thank you. Next slide.
Let's go. Yep, next. So this chart here just shows that it's going to take some time to get the model fully engaged. So what you're looking at there are some estimates for the member engagement as time goes by based on the different stages of kidney disease. So for example, on the left there, you'll see that for stage 3, in year 1, we don't expect a huge engagement rate for some of the stage 3 patients, slightly larger engagement for stage 4 and or in year 2 and year 3. And then of course, as you go to the right, more engagement as time goes by, and also higher levels of engagement for people with more severe forms of kidney disease. So that's just what we expect given what we know about the patient population. And so the impact of the program will be smaller in year 1, but it will gradually get larger. All right, let's go to the next slide. So in terms of some financial projections, so we think that the gross savings from this program could exceed $3 million a year once we get ramped up and get a high level of engagement. Now that's gross savings and not net savings. So in order to capture that $3 million, there's going to be a significant investment in care management and coordination, mostly in the form of vendor fees. So that's going to offset some of the savings. Fortunately, when we're talking with our vendors about how we're going to do this, we have performance guarantees that guarantee a positive return on investment. So there's no problem there with making those investments in terms of what the payoff is going to be. But there's still just some more work to be done to get the actual exact premium impact. So we'll be coming back at a later time with a specific estimate of that. Okay, let's keep going.
Let's talk about our musculoskeletal program using the framework of prevention, steerage, decision support, and surgery support. Some highlights: the MODA 360 navigators connecting with members, wellness advisors providing economic worksite assessments, virtual physical therapy, which will go into some details about the benefit design, and the centers of excellence concept that we're developing further. Next slide, please. Looking in detail at virtual physical therapy, we're evaluating technology-enabled virtual physical therapists. Essentially, the vendors have a variation of a device. Either they provide a device like an iPad, or it utilizes the member's phone. The device has a screen and a camera, and there's an app loaded, and the app is pre-programmed with a variety of activities that can be undertaken, but also with customized specific programs. Typically, there's also live in-person support, even though typically the whole exercise is not done live. Often bands are worn over the relevant parts of the body that are being analyzed, and that just helps sensors to detect and track the actual exercise and ensure that it's working as intended. We are prioritizing the following functional requirements. So really ensuring it's very easy to set up and use for the member. I think that's going to be critical for high engagements. Ideally, it should be an enjoyable experience. Cost is critical, ensuring that the offering is low cost, high value, and that there are good clinical outcomes achieved. Potential benefits of this type of solution are that it is highly scalable at minimal cost, but then any number of exercises can be undertaken by that member as frequently as they would like, compared to, as you can imagine, the physical in-person setting. It can be rapidly personalized through the software and is evidence-based, enables self-management at a time and location that's most convenient to the member during the day, at night, in the evenings, and really to the extent that typically the amount of volume that they would like to undertake of the therapy. Also enables early and ongoing intervention when face-to-face appointments are not practical, either because of their employment or where they live, or of course during the COVID pandemic. The range of conditions, it's really all joints, and it's both soft tissue and joints. It can be both pre-surgical and post-surgical. And the assessment is typically of the range of motion, along with a variety of functional outcomes, and there are established measuring scales for both assessing and monitoring progress in these areas. The vendors report the following outcomes. So clinically, they look at reductions in ED visits, reductions in the amount of surgery needed, as well as opiate and other pain medication use. They're achieving reduced levels of pain, anxiety, depression, with improved productivity and reduced fatigue. Other outcomes they're looking at are engagement levels with the platform, satisfaction levels in terms of net promoter scores, and overall cost benefits. And we have some data to share here.
So again, it's some OAB data to put this into context. So OAB spent $60 million on musculoskeletal conditions last year. So that's no surprise to anybody here. You know, it's something on the order of 10% of the total dollars went to musculoskeletal conditions. So it's a pretty significant cost area. This chart just shows how that spending is broken down by the type of service. And this includes medical only. It doesn't even include pain medications. So it's even higher actually than 60 million once you include some people on opioids and other drugs. And in fact, you can also see the top five or so rows of the table. If you look on the far right there under unit cost, that's where the expensive stuff starts to get when the more conservative treatments don't solve the problem. And you have to have inpatient admissions, emergency room, or surgeries, either at ambulatory surgery centers or hospitals, all get pretty expensive. And so the idea here is, you know, maybe we can influence some of this with this program and keep people in sort of the bottom part of the table where you have, you know, office visits and, you know, therapy services, which are much less expensive.
So
and
Bill,
yeah,
the other professional services would be OT, PT, chiropractic.
Correct.
Doctor. Okay.
Yep.
Thank you.
Okay, so let's go to the next slide, and we have on the next slide some estimates. So these some of these come from vendors, some of these come from white papers and industry research on these types of programs. Just an indication of why we're looking at them. So things that you see are, you know, 50% reduction in surgeries or 50% reduction in imaging. One of them was, you know, documented a 65% reduction in emergency room visits related to musculoskeletal conditions. So some pretty dramatic results for people who are engaged in using this type of service. As you can imagine, just the convenience of it, to be able to have this done in your own home at your own schedule. It just has the potential to really impact musculoskeletal spending. Some caveats there, as the bullet points on the right that we'll just go through is, these estimates would just apply to the engaged population. So it's you can only impact the number that chooses to get engaged in this, and the engagement's probably going to be challenging because there's so many members that have musculoskeletal conditions. How do you get all of them connected to the virtual PT program? It's going to be difficult. But even just to throw and it's going to be hard to predict, and it's going to depend greatly on the communication strategy and rollout of this. But you could just imagine even at just a 5% reduction in that musculoskeletal medical spending is $3 million a year for OWEB. So pretty significant opportunity if we can direct people into a program that is like this. So anyway, we're, again, similar to the ESRD, we're still working through the vendor selection and working on a more precise estimate of the premium impact. So that's going to be coming. But we just wanted to put this up here just to give you an idea of the compelling nature of why we're doing this, and what we think, is just maybe some ballpark estimates for what the impact would be.
Great, and now we're going to transfer back over to Dr. Singh, who's going to talk to us about how we're looking at Centers of Excellence at MODA. Dr. Singh?
Yeah, thank you. We have strong interest in further developing the concept of Centers of Excellence, and here I'd just like to highlight some of the priorities. One is essentially high quality care, so using nationally recognized evidence-based process and outcome measures as a key requirement for our Centers of Excellence. It should be cost effective, produce high value for members, typically in a value-based payment arrangement. Bundles work well in this setting. We would like to see both upside and downside risk models for our Centers of Excellence with risk adjustment for case complexity. Service excellence, we believe, is critical. It's got to be convenient, have to consistently achieve high satisfaction using real-time surveys. We'd like it to be highly engaging. We'd like to choose shared decision-making early on, so it's patient-member driven. Their preferences are discussed really early on in any particular clinical condition or pathway. We're looking at Centers of Excellence as also supporting full care pathways with pre and post follow-up experience, and ideally highly tailored to patient preferences and taking into account aspects such as their activities of daily living and the support they have in the home setting, and incorporating all that in determining an appropriate care pathway. Access to care is a high priority for us. We'd like to see the centers being available all across Oregon, including Eastern Oregon. Localized care whenever possible. So we're not thinking of Centers of Excellence purely as academic quaternary care centers, though they will excel in many areas, but also we'd like this standards to be achievable in a variety of hospitals and other settings of care delivery. Looking at our networks today, we have areas of enhanced care, and look throughout specialized conditions and generalized healthcare, and we believe the vast majority of care is available within the state of Oregon, though Washington would be included as well for certain areas. We're certainly open to other states being offered to our members, but we believe this would be on very rare occasions for really rare procedures. We have what we need within Oregon. And we'd like it to be easy to access and utilize.
So question, there's a sensitivity along the Idaho border. Are there any options over there?
Yes, there are options in Boise and closer. And our goal is to prioritize access throughout the state, looking at each member and looking at what is most physically convenient. So we'd go program by program, condition by condition, literally map out the journey, physical journey that the patient undertakes, and we'd incorporate all those factors to ensure that we're giving them the best sort of overall experience, cost, outcomes.
Thank you.
Reliability and consistency is another key thing we'll be looking at. With centers that provide very low error rates, very low complications. We'd be therefore tracking readmissions, for example, and looking at high volume for those types of procedures, utilizing existing accreditation standards wherever possible. And there are external bodies, therefore, that do inspections and assessments. They validate facilities, process and outcomes. And where necessary, if we're talking about a variety of hospitals or settings in parts of Oregon that don't already do this and there's costs involved, we're interested in supporting that from a MODA perspective and potentially bearing some of that cost to ensure that they can also meet accreditation standards wherever appropriate. That's part of our goal to improve access and have multiple sites of care. We talked about the full care pathway approach with interdisciplinary team-based care, significant care coordination, ideally concierge service. That could include pre-referral guidance, video-based follow-ups, for example. We'd like this to be a broad range of conditions rather than just rare or expensive conditions. And this would, the approach would essentially leverage our existing network, but add a much higher level of analytics and enhancements to that. Thank you.
And before, let's go back one slide, if you don't mind, because there was one question from Bill, I think, about, and I'll just, so Robin, I think this is for you. He's asking if musculoskeletal diagnoses are like cancer and that earlier detection and intervention might reduce the overall cost.
And sorry, the key question is in the context of musculoskeletal conditions, yeah. And whether or not
similar to some of the other chronic conditions where earlier detection intervention might lead to better costs.
Yeah, we certainly do believe that would be the case. When you're comparing something like CKD or cancer or so on, it's not as easy to get that cost effectiveness analysis early on. The clinical and the cost profiles are very different. So we're comparing very, very different types of conditions, musculoskeletal being sort of very, very broad, much more prevalent, whereas CKD, although common, still much smaller numbers. With all these conditions, early detection is a challenge. Most of those CKD, the 10% we mentioned, for example, are not actually detected. So thus the OM member numbers are much lower. That is all that in that sense, that's similar with musculoskeletal. So I'm not sure that's getting to the exact question.
This is Tom. My response also to Bill is that the issue around musculoskeletal is that while so much of it is the micro traumas of wear and tear, and that early diagnosis and addressing the issue is helpful, but it requires substantial lifestyle changes, with quitting smoking and exercise and avoiding the activities that worsen it, and weight loss. So it really is, as compared to like colon cancer screening, where you get screening and you find the disease early or polyps before it becomes cancers, and you take them out and you substantially lower your cancer risk. It's much more like, addressing lung cancer, where you have to go through the difficult issue of quitting smoking in the vast majority of people with that condition. But there is evidence that addressing musculoskeletal early on definitely makes a huge difference.
Yeah, thank you. That was very well put. Yeah, it's different in that sense. A narrow, specific, measurable with something like the cancer, bit much broader approach to musculoskeletal. But I agree fully that there is still nonetheless good evidence. Thank you.
Okay, well let's keep going and into the next section. So we have advanced imaging steerage. So you know, I was sitting here thinking about presenting this slide, and part of me, I don't want to necessarily get people riled up about this because you look at something like this, and I think the members of the CL have seen charts like this before documenting cost variation. This is just sort of your bread and butter chest CT. And this chart shows the range of prices. Most of these procedures cost anywhere between $600 and $1,000 at imaging centers, etc. But there's quite a long tail, and in fact, a significant number of these where the cost is exceeds $3,000 for this very same test. I was looking at some claims the other day. One from a small hospital out on the coast, and it's like more than $4,000 for the very same procedure. And there's just that's just the reality that hospital-based care is more expensive. The hospitals have higher overhead, and it just is that's just the reality of the world we live in. And so, but the point being is that we feel like even though some of this is a little bit outside our control, but what we certainly can do is provide some more member education so that they can make the decision that's best for them, and also give them the information that they need so they can go to the facility of their choice. So, members generally don't price shop these services, and that's probably why you end up with a broad range like this.
Right.
And then also you've got the situation that the physicians that work for some of these hospital health systems, they're going to refer to their own system. And so that's why you're just going to consistently get members referred to the highest possible cost of care site. And so, there's a lot of ways that you could try to address this. None of them, well, I should say every one of the ways that you could try to address this has negative implications. But the way that we're proposing to do this in the coming year, I'll describe on my next slide. So we'll just go to the next slide. And this is just a sort of a pilot program that we're kicking off, where basically how this would work is members can still go to any facility. If the request for prior authorization for advanced imaging comes in, we're still going to approve this. But what we are going to start doing is just, it's going to trigger a member outreach to have one of our health navigators, that's part of the MODA 360 program, just let the member know, hey, we see that you're intending to go to this facility, and it's certainly you can go there, but did you know that given your plan and deductible and coinsurance, that's going to cost you X, whereas down the street you could go to Epic Imaging or Clearview MRI or whatever you want, and you get the same exact test, and it's going to cost you this much less. So there's going to be a lot of cases where we'll provide the member that information, and they're still going to elect to go to the hospital because that's what their doctor told them to do. But we expect that a pretty significant percentage of the time the member might decide, you know what, I'm just going to go to the less expensive one. And so we're going to leave that up to the member. This approach, what we're going to start doing is, or I should say, just to hit the points on the right hand of the slide there, the program will be optional, so the member is still going to make their own decision. And what we're just doing is starting out small in a pilot program so that we can make sure that we're going about this in the most sensitive way with the best communication strategy, and just sort of start slow and fine tune it. So that's kind of our plan for this for 2021.
Thank you, Bill. And the one thing that I would add to that too is when the navigators do reach out to members, they can also assist in scheduling the appointment with the lower cost option as well. So the navigators are definitely there to help the members in whatever way that they would like. So thank you, Bill. Any questions about that pilot program before we move on? Great. All right. Well, we now have Dr. Barrichello, who's going to talk to us about medical and dental integration with MODA 360.
Thank you. Can you hear me okay, Erica?
Yes.
Perfect. I'm sorry, I'm not on video. I'm having some bandwidth issues, so I'm on my phone to try to hopefully minimize any risk of the entire presentation dropping on me. Well, I'm really happy to be a part of the team today to talk to you about the further enhancements to MODA 360, and one in particular that's obviously really important and exciting to me, which is the addition of dental. So the launch of MODA 360 brings, I would say, all kinds of opportunities across our enterprise to help support members and further promote the importance of health, and specifically here, the importance of oral health as an integral part of overall health. And it's a really significant step in our efforts toward medical dental integration. So by adding dental to the MODA 360 program, the health navigators and care management teams will now have an integrated view of members' health information. And this will obviously help our members in several ways, and as it relates to dental. We're going to be able to identify members who have not had a recent dental visit, to be able to connect them to their provider of record, or help establish care with a new provider if that's necessary, or if they don't have a dental home. And we'll be able to identify lapses in the frequency of dental services, trying to make sure that where appropriate, people are getting at least one visit a year, if not more, depending on their specific risk, and really working to close those gaps. And importantly, we'll be able to integrate oral health education and information for members with chronic medical conditions on the role oral health has in their disease management, and connect them to appropriate resources, because it's not well known in the public space how the mouth does play into like their overall health. So helping bring that to light. So for example, if someone on our care management team is working with a member who has diabetes, the MODA 360 dashboard will display information not only from the medical side, but also about the member's dental claim history. And if there aren't recent claims for, say, preventive care, they'll emphasize the importance of regular dental care and help the member understand the implications that oral health has, specifically as it relates to the management of diabetes. And we believe that this holistic and integrated approach to health management will further improve utilization of preventive dental services. And I believe it's going to ultimately improve overall health outcomes. And that's all I have, but I'm really happy to take any questions.
Sounds great.
All right. Well, thank you, Dr. Barrichello. Oh, did you have a question, Dr. Siltabo?
Yeah, my only this is the one that actually has a number associated with its impact for premium. Is that something that you want to discuss further, or we'll discuss when we get to the board?
Yeah, so I do know that Willis Towers Watson has it included in their renewal packet for this afternoon. And we can talk about it. As we mentioned on the other initiatives that we had that we discussed today, the virtual PT and then also the kidney care program, we are still working through that vendor process, and we'll have more specific information on savings or costs for the next round, but do not have that detail as of today. But we did include this detail here because we do have it.
And that was that's the lead into my next question. We've just talked about efforts aimed at chronic kidney disease, musculoskeletal disease, advanced imaging. Do you, and those were, in a way, I viewed them as introductions of what you're looking at doing. Are you thinking of bringing these back to CIAL for further vetting once you get closer to numbers?
Yes, I was thinking that would be an appropriate next step for those initiatives.
Yeah, sounds right to me. And again, I think the board, and Jeff, you can chime in here, but I think the board appreciates CIAL's, in a way, greater depth in looking at these issues, while still the decision about adding is definitely the board decision. I think having CL vet these is something that the board in general appreciates.
Yeah, great.
Well, tossing it back to you, Tom. This all sounds very good to me, and we rely on your medical perspective to ratify that position.
Yeah. I think that, go ahead. I think, Robert, were you?
I was just going to say, with any piece where there's an increase attached, I like seeing, over the next year, and we do this consistently, what's the measure for success on that? So I can see it with the chronic kidney disease management, but I'd like a little bit more vision, not today, but on what would success look like.
Yeah. So, Glenn, if you're on listening in, it'll be important to make sure that we have time as MODA comes forward with these thoughts for us to do again a greater dive into what as these ideas get refined, and then as Dr. Singh talked about, there being and Bill also discussed this issue of it taking time and investment to get to a point that you get a return in terms of decreased utilization and cost. We understand that. That's just something that we need to understand and then go ahead and give the board recommendations.
Yeah, if I could editorialize on one more thing, is on the advanced imaging. That's been a consistent topic for the life of OWEB, and we've made good progress, but it's just it's one of those issues that where continual vigilance just helps us manage those costs.
Yep. It's where, and it's unfortunately, it's where advanced imaging, and Bill, you described the $4,000 chest CT. There is, someone can create a rationale for trying to justify that. However, the end result is, particularly in situations where people have significant deductibles, they get whacked in the face by that, and people don't. That when you go to the hospital or the emergency room, you because you've fallen and bashed your head and you had a concussion, you don't go there checking out first how much is it going to cost for me to get the test. You go there because you're in dire straits, and people just get whacked by this stuff, and it's that's part of our job, is to help protect people from that. I have it is 11:58 for the summary of this last section. I think we're going to say we're interested in all of the ideas that MODA is coming up with, and that we will do deeper dives as we get closer to the actual rate setting process. Is that a fair summary? If yes, I'll go ahead and say we're done for the morning, and we get back together at 1. Any other comments from staff for committee members? Okay, another on-time arrival.
Way to go, Tom.
Thank you much. Thank you all.
Good
Wonderful, excellent work. Excellent work from our consultants and our health plans and dental. Bye-bye.